Thank you all for coming. Hopefully we can give you some good information tonight. I'm a family doctor in Huntsville. I've been there since about 2006, born and raised there, and then came back. So I've known Bracebridge for a very long time. And this is Ava. She's a student with us for the summer doing some research, and she's helped me with this presentation. So I'm hoping this can be helpful for you. So I guess I would start off by saying we want to come and talk about type 2 diabetes, give you some education about what it is, and how you can potentially prevent and treat it. Before I get into that, though, if anyone has anything that they'd like me to talk about, does anyone have anything in specific they want to know? Please raise your hand now or let me know. Just put your hand up at any point because, we're a nice small group, so hopefully we can make this useful for you in the time that you're here. And if we completely deviate off the course, I'm okay with that too. Okay. But we are hoping this will be educational, but we wanted to start off with something fun. Just for what we're going to cover tonight, we wanted to talk just in general terms about what diabetes is, a little bit about the science behind it, so we can explain to you kind of what's happening in the body, risk factors for developing type 2 diabetes in specific, symptoms, complications from that, and then what you can do to either prevent and or treat it, because they are basically both the same kinds of interventions lifestyle-wise that will both be preventative and how we treat this as well. But first, we're going to start with something fun. So just wondering if anyone has played or watched Who Wants to Be a Millionaire? A few? Okay. So hopefully this works. We're going to start off with some sort of trivia questions, and I'm going to get Ava to ask you these questions, and I'll turn it over to her while she does that. And please just yell things out, raise your hand, however you want to do this. Let's just make it fun. Okay?
There are some sound effects, just to warn.
I wanted to make it authentic.
So the first question that we have, which of the following is not one of the top 10 chronic diseases in Canada? We have answer A, cancer, B, high blood pressure, C, type 2 diabetes, and D, celiac disease. Everyone says D?
Yep, great. And unfortunately, there is no $1 million, so, but you will have knowledge when you walk away.
So you are correct. The answer is D. Couple more questions here. And it's the same sound effect every time. Just in 2020 to 2021, how many Canadians were living with diabetes? C.
Everyone you guys are C. Smart. You have to. Did that she? Oh yeah, I did give you the answer.
Correct again.
So really high number. I don't know if you've seen that stat before, and this number is on a daily basis increasing, and has gone up over the last year as well. So it's definitely something that we need to do better at in terms of prevention.
Last question, which of the following is true about diabetes? A, type 2 diabetes is more common. B, you should not exercise with diabetes. C, diabetes is caused by eating too much sugar. And D, everyone with diabetes requires insulin. Okay.
I should have made these questions harder, I think, okay? Okay, next time.
And you are correct. The answer is A.
Okay, so there'll be a few questions. I'll leave that for you. There'll be some questions along the way. So hopefully maybe I'll stump you on one of them, but okay. So just talking about diabetes in general. Can you flip that slide?
Sure.
So just in terms of, clearly you're all aware that it's a very large number of people who are affected by type 2 diabetes. Diabetes is actually the 5th most common chronic disease. That comes after high blood pressure, arthritis, depression, anxiety, and osteoporosis. Most deaths are typically related to its complications being heart disease, stroke, or kidney disease. I don't have this up there, but in 2019, our Simcoe Public Health data reported that we had 55,000 in the Simcoe Muskoka area who were 20 and over with type 2 diabetes. And that had increased from 34,000 in 2009. So that equates to about 1 in 10 adults in Simcoe Muskoka who have diabetes. So for all these reasons, we need to do a better job at screening for diagnosing and managing, but more importantly, in preventing diabetes, which hopefully we'll have some useful information today. So every 24 hours, more than 20 Canadians die of some diabetic-related complication. 480 Canadians every day are diagnosed with type 2 diabetes. 14 Canadians per day have a lower limb amputation. And hopefully that number is improving as we get better at managing sugars and providing education. And we spend an inordinate amount of money on diabetes and its complications. So what is diabetes? In just a very general sense, diabetes is a disease where your body does either not produce enough insulin and or the body's cells are resistant to that insulin. Usually it's a combination of both, and that progressively gets worse over time, which is the natural history of diabetes. You're going to produce a little less insulin and you're going to be more resistant to the insulin that you do produce. That leads to glucose accumulating in your blood vessels. And as you all know, your blood vessels go everywhere. So that means you can cause damage to the eyes, to all of your organs, including your heart, your kidneys, and what we call your peripheral nerves, which are the nerves that typically go to your hands and feet. And you may know people or have known people with diabetes who get numbness and tingling, usually in their hands before their feet. And that's related to the damage that sugar causes in the blood vessels and its nerves. So in terms of, this is a pop quiz, and maybe I'll get you on this one. So the question is, does adult onset diabetes refer to type 1 or type 2 diabetes? Okay, so it was kind of a trick question because we don't actually use these terms anymore. Historically, we used to say type 1 was child onset, type 2 is adult onset, and we know now that kids can develop type 2, adults can have type 1, so we don't use those terms really anymore. It's similar to how we used to say insulin-dependent diabetes or non-insulin dependent diabetes. Both types of diabetes can require insulin, but they don't have to. So we typically use now the terms type 1 and type 2, but yes, you're right. Historically, would say adult onset was type 2. Unfortunately, as we see kids having higher rates of obesity, we're seeing that rate of type 2 diabetes going up, particularly in Indigenous populations. So just for type 1 and type 2, I'm not going to talk a lot about type 1, but type 1 is considered non-preventable. It's an autoimmune condition where your body's own antibodies attack your cells and breaks down the pancreas so that it actually doesn't produce insulin, which is why type 1s typically require insulin to replace what they're not producing. It's not as common as we talked about earlier and is generally about 5 to 10% of cases. Type 2, which is what we're talking about today, is preventable. There are some genetic risks, which we'll talk about a bit later, but typically treated with either lifestyle changes and medications, and attributes to 90 to 95% of cases. So in general, the science behind diabetes, oh wait, are we at a question here? Yeah, okay, sorry, this is Ava.
So we just have a little question to get right into the science. Insulin is produced by the liver. Is that true or false?
Yeah, produced by what organ? Pancreas. Okay. So in terms of just normal metabolism, when we eat things, our carbohydrates are broken down into glucose. So typically when people are like, oh, I eat too much sugar, it's not actually the sweet candies and things, it's also the breads and everything that is our carbohydrates and starches that get broken down into our glucose. That glucose is then stimulates the pancreas to secrete insulin, which is required for your body's cells to take that glucose into the cell and use it for energy. So when the insulin is around and effective, the glucose gets into the cells, and it also goes into the liver, where it stores that glucose in something it's called glycogen, which we use for later when we haven't eaten in a while. We start to break down the glycogen, so we have glucose again. So it's important to have some readily available in our cells for energy, but also to store some for those times when we don't actually have food available to us, or we're, missed a meal or something, then you start breaking down that glucose store in your liver. So in diabetes, that insulin is either not there in enough quantity, or your cells are resistant to it. So that glucose that should be in your cells and in your liver is staying in your blood vessels, which causes inflammation and damage to those blood vessels.
So there are some risk factors associated with type 2 diabetes. These include men, people of age 40 or above, being overweight, a lack of physical activity, high blood pressure, smoking, a family history, and this is particular for first-degree relatives, Indigenous African, East, and South Asian populations. And this is likely due to genetic risks and a lack of access to foods and care. There's also some medications that can increase your risk of developing diabetes, such as steroids and atypical antipsychotics. And then we also have people who have schizophrenia, vascular disease, polycystic ovary syndrome. Many of these risk factors are not modifiable, but we can impact our weight, level of activity, blood pressure, and whether we choose to smoke to help prevent some of these risk factors. There's also symptoms that we can look at. So some people might not have any symptoms at all, and this is important to note because that is something to definitely keep an eye on. Unusual thirst, frequent urination, weight change, extreme fatigue, blurred vision, frequent or recurring infections, slowly healing cuts and bruises, tingling or numbness in the hands or feet.
And usually, the tingling in the hands or feet is usually a late onset thing. So if you're developing that, it's usually because you've had poor sugar control for years. So people don't hopefully don't present to you, the physician like that. Hopefully you're catching it beforehand. Most commonly, people have no symptoms. And which is why it's important to be kind of seeing your provider regularly. We do screen for this every few years, starting at the age of 40, which we'll talk about. But that's mainly because most of us don't have any symptoms. So in terms of screening, for the average risk person, we're doing this every 3 years after the age of 40. If you're higher risk, so if you've had a heart attack, you've had a stroke, you've been taking medications or certain things that put you at higher risk, then your provider may choose to screen you a little bit earlier or more frequently. Does anyone have an idea of what hemoglobin A1C is? Yeah. There you go. Okay. So your hemoglobin A1C is an average of your sugar over 3 months, and it's taken from your red blood cells, which live for 3 months, which is why it's a good picture and representation of how good your sugar control is over time. Your doctor or your nurse practitioner probably would tell you it doesn't matter if you've eaten, you can go, you don't have to be fasting for this test, which is helpful. So because it's looking at it over an average. As opposed to if I check your sugar right now, it's what it is in this moment. So this gives us an idea of how good your sugar is being controlled. So basically, we're looking for anything that is less than 6.5%. Once you get over 6.4% is what we call pre-diabetes, and over 6.5%, we consider that to be diabetic. There are other ways to screen for diabetes. Personally, I find them a little bit more complicated. Like you can do a fasting glucose. You can do what's called a glucose challenge test, which you drink some sugar and they measure your glucose uptake over 2 hours. But most of you, for sort of average risk screening, you're going to have a hemoglobin A1C as your marker. In terms of complications, as we talked about before, because your blood vessels go everywhere, it can affect everything. So the most common cause of blindness is from diabetic retinopathy, which is why if you have diabetes, you should be seeing an optometrist every year. It is covered for diabetics, and they're looking at the blood vessels at the back of your eye to make sure there's no damage to them, which can potentially lead to blindness. Most common cause of complications from diabetes is oftentimes kidney damage. Again, you do not have symptoms from kidney damage, so it can sometimes cause high blood pressure, which can be asymptomatic as well. So your doctor or your nurse practitioner typically will check your kidney function at least every year. So by checking a urine sample, we can see if you're leaking any protein into your urine, which is often a sign that there is damage to those blood vessels to your kidneys. And if you're leaking a lot of protein into your urine, we try to get tighter sugar control, tighter blood pressure control, just to prevent that from worsening over time. Higher risk for stroke, higher risk for heart attacks, and then diabetic foot infections and peripheral neuropathy is the numbness and tingling in your feet. The diabetic foot infections, as you can imagine, are a higher risk for people who have peripheral neuropathy. So when you can't feel your feet, you don't necessarily know you've got an ingrown toenail, you've stepped on something and had a cut, and so you're not aware of potentially an infection or a wound that is not healing because you can't feel it. And this is historically why you'd have a lot more amputations, because people wouldn't notice it, and then you'd end up with toe amputations, foot amputations, which clearly we still have. So it's important, if you have diabetes, to be checking your feet, ideally every day. So if you have a partner who can look at the bottom, just make sure, okay, everything looks intact, the skin is closed, there's no open sores. And once a year, your provider should be checking you with what's called a monofilament test, where they take a nylon filament and they just touch the bottom of your foot to see if you can feel it. If you can't feel it, then that's a sign that maybe you're getting some nerve damage to your feet, which then prompts us to be a lot more diligent about checking your feet regularly and checking for wounds. So in terms of prevention and treatment, so the prevention and treatment other than medications is the same. So how we treat our bodies in terms of our diet, our exercise, and the risk factors that we impose on it in terms of smoking and alcohol, those are all things that we can control. And nothing that I'm going to say to you today is going to be news to you. You kind of all know this, but I just want to reinforce to you and hopefully give you some practical tips on how you might change your diet, how you might try to be more active. And if you're looking at trying to quit smoking, we have programs locally that will help you do that. But essentially, in terms of lifestyle management, the prevention and treatment is the same. So we'll go through a little bit of this. But first, I think we have a question for you.
So we have some questions regarding having a healthy diet, and we'll go over the answers afterwards. But the first question is, what is the better choice for breakfast? We have all bran cereal versus Rice Krispies. Okay. Next, what is the better choice for breakfast? A pear versus a watermelon.
Okay, I'm just gonna hold on. Okay, so I will get to the answer in a question in a minute. But does anybody know people who answered? You're all right. Any idea why those foods are better? Yeah. Okay. What about the fiber? Do you think makes a difference in terms of glucose management? It's okay if you don't know. You seem like a very intelligent bunch, so I'm just putting it out there, and I will explain it. Yeah, for sure. So, okay, hold that thought, and then we'll just ask the last question here, and we'll talk about it a bit more. I don't know if you guys could read this. So, sodium is also an important part in terms of blood pressure management, which is important for diabetes. So, this is a question that I was going to ask in terms of label reading, which we all have been told we should do. So, if you look at this and you look at the Ritz crackers, I can't read it from here. So, hang on. Does that say 130? My screen's really small, so the sodium in the Ritz crackers is 130 milligrams for 16 grams of a serving, okay? The Ritz crackers is 160 milligrams for 28 grams of a serving. So it's a bit of a trick question, but who would say, which one would the better sodium option be? Any takers? Yeah, this is where label reading becomes a little bit tricky. So it's all fine and good if we say, read the label. But yes, you are right, it is Triscuits, because although the sodium intake in the Triscuits is higher at 160 milligrams, the serving size is different. So when you're looking at the label, you kind of have to say, when I eat this much, I get this much sodium, and if I eat this much, I'm going to get more sodium. So it's not just about the number on the label, it's about the serving size, which is why it was kind of a bit of a trick question. And label reading is something that we should do in terms of looking at sodiums and saturated fats. So I would just encourage you, if you're trying to do this on your own, both communities, Huntsville and Bracebridge, have dietitians that you hopefully have access to that can help you with this label reading. But just be sure to kind of look at the serving size as well, because with marketing, they like to show you the best possible scenario, but oftentimes, are you really going to eat 2 crackers? Probably not. And so that's when the sodium really comes into play. Okay. So just going back to what was better about the pear and what was better about the all bran. So has anybody heard of glycemic index? Yeah. Okay. Care to venture a explanation? Right. So essentially, it's how much the glycemic index is a measure of how fast the food breaks down and how quickly your sugar spikes in your blood vessels. So yeah, that part is correct. So foods that are white, foods that get broken down super fast, so Ritz crackers, white rice, white pasta, they actually have a high glycemic index. You want to try to avoid the things with a high glycemic index. If you go on and you Google foods with high glycemic index, you'll come up with like a whole bunch of starchy foods, basically. And those are the ones that, like this gentleman has said, they'll spike your sugars faster, which causes more inflammation in the blood vessels. So you want to minimize that as much as you can, which is why all bran and things with fiber, you get slower uptake of the sugar, which is better for your blood vessels. Okay. So in terms of how you in general can eat better, you want to eat more foods that have a low glycemic index, okay? So the things that are broken down slower. In general, I tell my patients, just eat more plants. Eat things that have color. Make sure there's a variety on your plate. Lots of water. Try to avoid, the extra calories that are in juices and sodas and even dairy products like milk and things have high amount of calories. So more water is better. And I'm sure you've heard lots about the good fats versus the bad fats. So good fats being things like olive oil and avocados and some nuts, and trying to avoid really anything that has saturated fats, which is all the things that we like to eat. So that's trying to be aware of things you should try to maximize. And then in terms of things to try to avoid, again, it's those highly processed foods that are already kind of broken down for you. So refined flour, refined sugars, processed things spike your sugars faster, and they have less nutrient value to them. In general, eat less of anything that comes from an animal. That's meat, fish, dairy. Okay? Again, things that are high in our Western diet. Eat less, just in general. Your portion sizes, we all eat in Western society probably just too much and too much portion size, and less alcohol. This is what your plate should look like. People have probably seen this before. If you go to, some of the favorite restaurants, you typically see the reverse of this, where you have a tiny bit of salad and a huge amount of protein and carbs. So there's this kind of pictorial where you can just say half my plate should be fruits and vegetables, a quarter can be protein, and a quarter can be carbs. And again, those carbs, you want them to be whole grain things, as we talked about, higher fiber, nothing white if you can avoid that. The other way to look at this is the fist rule or the palm rule. Has anybody seen this before? Yeah. So one palm should be basically your protein, one palm should be your carbs, and 2 palms should be your fruits and veggies. And the thumb tip is all the fats that we try to avoid. Practical tips. So what can we do? It's difficult, I find, when I'm talking to my patients to be like, I can tell you, okay, read the labels and do this and do that. What I try to tell my patients is pick one or two things that you think are doable, things that don't completely turn you off and demotivate you. So some of the things that I often will talk about is just try to be mindful of the mindless eating, which is in front of the computer, in front of the TV, you got your snacks at night. So just if you're going to do that, choose what you're going to eat, put it in a bowl. It's very tempting and it's very easy to eat a bag of chips, but it's more conscious for you to put it in a bowl and to eat what's in the bowl. So mindless eating, if you can watch out for that, is helpful. Meatless meals. There are lots and lots of good recipe books now that are vegetarian and vegan. So it's not as scary and inaccessible as it used to be. Reducing the fat in your dairy products. So as low as you can go with dairy, down to skim if you can tolerate it. You actually don't need, personally, I don't feel you need dairy in your diet if you're getting calcium from something else. So if you're going to eat calcium-rich foods, kale, salmon, green leafy things, you don't need to be drinking milk. There is an Osteoporosis Canada website that is very good, that if you go on to osteoporosis.ca, it talks about your calcium content. So you can put in, I eat this, and it'll spit out how much calcium you eat. And you generally want to be around 1,200 milligrams. So if you can get that in your diet, it's better eaten than swallowed in a pill. But the Dairy Farmers of Canada has been very good at marketing to make us think we all must drink milk, and that actually isn't true. Yeah. Yeah. So, I mean, the almond milk or oat milk or any plant-based milk is going to have less fat. It's now there's other debates about the downside of plant-based milk, which is now starting to come out as there's lots of marketing around it. So just, I don't know, this isn't really science-based, but my understanding for almond milk in terms of nutrient value is it should be lower fat. It may not have as high a calcium intake for it. The downside of almond milk is it takes a ton of water to produce it. So environmentally, it's not great. But then you can argue that having a ton of cows isn't great either. So, but I would say to most of my patients that a plant-based milk is generally better than a fat-based milk. Yeah. I think it's always, if you have the time and the ability, better to know what's in your food. I think when you said exactly highly, like the processed stuff, there's often a lot of fillers in there. So there are a lot of good recipes that you can do that are quite simple. You throw black beans and you make a black bean burger. There's lots of good recipes that way that are not overly complex, that are going to be cheaper for you in the long run and also have less of those extra things that you don't necessarily want, whether that's sugars and other kind of refined things. Yeah. Eat regular meals. So, we all kind of fall victim to we're busy, we're running around, then we snack. And when we snack, we often choose things that are not the most healthiest of choices. So if you can try to eat your meals regularly, you have a better overall glycemic control. It's not spiking and dropping and making you hungry through the day. Eat more colors, eat slower, and with family or friends, which tends to make you eat slower. So by doing that, by socializing, you're engaging in that process, people tend to eat less and slower, which allows your brain time to hear the signal that you're full. So you're not overeating because you're not paying attention. We talked about reading labels for salt and for fats. And if you're really interested and want to actually sit down with the dietitian, you have a family health team here. There's a family health team in Huntsville. If you have a provider and have connections to that, our dietitians there or through the diabetic center are always happy to sit down and kind of go through diet with people.
So we're now talking about preventing diabetes with exercise, and I just have two true or false questions to start off. The first being you should exercise an hour every day. Are people saying true? Not necessarily.
Okay,
Interesting.
we'll get to the answer and then we'll discuss. Okay.
And walking has an equal benefit to strength training. Okay, interesting.
Okay. So we're going to talk about this a bit more and hopefully we answer those questions for you. So the exercise recommendation for aerobic activity, which I'm sure you're all aware, is like walking, biking, swimming, things that you sustain that effort for 10 minutes or more. The recommendation is 150 minutes a week. So it's not an hour. It's not overly ambitious. You can break that into 2 sessions a day. You can, as long as it's kind of 10 minutes at a time, you could do 10 minutes twice a day. But it's 150 minutes a week. So if you're going to do 10 or 20 minutes a day, it's actually not too much. And that can be really anything that motivates you to get out and be active in a moderate to vigorous level of activity. The strength training is also, it's equally important. So I wouldn't say it's more or less important, but it is a recommendation that you do some kind of strength training 2 to 3 times a week. It doesn't have to be heavy weights. You don't have to go to the gym and pump iron. You can do that with body weight, resistance bands, your home gym, like just kettlebells and things like that. And there's actually on the Diabetes Canada site, there are some links to exercise as well that can get you started if you're looking for those kinds of structured routines. And then there's interval training, which is short bouts of higher intensity alternating with lower intensity activity, which for some people is actually more motivating because it's like a short period of time, you just go hard and then you alternate it with lower intensity. And that has been shown to have very good benefits as well for your overall health, weight management, and your sugar control. But really my recommendation to anybody in terms of physical activity is do whatever motivates you to get out and pick things that you'll be able to stick to. So the benefits of exercise, there's lots. So obviously we can get our weight down, we build bone strength. It does drop your blood pressure by about 2 to 3 points at minimum if you're kind of meeting up that recommendation. Reduces your risk of heart disease and reduces your risk of cancer. Specifically for diabetes, you can bring your A1C down by improving your body's insulin sensitivity and your glucose control within your blood cells. It improves your cholesterol and it slows the progression of the peripheral neuropathy, which is the nerve damage in your legs. What I had looked up prior to this presentation is that the 150 minutes per week can drop your A1C up to almost 1%. So for some people, that makes a big difference and can be the difference between having to increase your medications or start a medication. So hopefully that is motivating for some, because lots of people that I talk to, they just don't want to be on medications. And it's sometimes not that diabetes is reversible, but you can definitely manage it with your lifestyle factors. I would say the other way around. Diabetes is a risk factor for certain cancers. And I'm not sure if they're actually directly correlated, but when you think about diabetes, you have a higher risk for having been a smoker, having had alcohol. So there's a lot of indirect associations. But I'm not aware that cancer is a risk for diabetes per se, unless you have pancreatic cancer or something that has to do with your insulin production. Okay. So in terms of other things that exercise is beneficial for, when you actually exercise, it increases the muscle cells' sensitivity to insulin. So what I would often tell patients is, if you're going to eat lunch, go for a walk after. Go for 10 minutes. It actually will increase the uptake of that glucose into your cells because the insulin is going to work a little bit better and you're going to be a little bit more sensitive to it. So you kind of avoid that spike in sugar just by going for a little bit of a walk, and you're less likely to fall asleep in the afternoon. So practical tips, just move more, stand more, park farther away. Again, take the stairs, just do what in your normal daily activity is going to move your body more. I talk often a lot about making manageable and realistic goals. And again, your doctor, your nurse practitioner can actually provide you an exercise prescription if that is helpful. There is evidence that if I write you something that says you're going to do this 2 times a week for 10 minutes at a time, that you're more likely to follow through with that. And I think that's just human nature. We're, creatures that want to be following the rules and kind of doing what we're told. And so sometimes that is a little bit more concrete, and your provider can also give you a titration where they're increasing it. So now you're twice a week, 10 minutes. Next week, you're going to be 3 times a week, 10 minutes. And then you kind of gradually work from there. In my practice, I often will just encourage people to start with something manageable. I'm not going to tell you to go from 0 to walking 7 days a week, because you want to be motivated. You want to see that you're able to achieve those goals to motivate you to continue. So the principle of the FIT principle has to do with frequency, intensity, and time, which has, if you break that down, it's like, how often are you going to do something? How long are you going to do it? And how often and how hard are you going to do it? So people will often start walking. Okay, I'm walking twice a week for 10 minutes. Okay, you've done that for a couple of weeks. You can't stay there. You need to actually progress to get more benefit. So you either do that walking more often in the week, you go up more hills, you go a little faster, or you go longer. So those are the kind of principles that if you're starting to be more active, that you can kind of think about how you want to grade that over time so that you're getting more benefit from the time you're spending. Exercise with friends. It's always good to be accountable to somebody. It's much more, you're going to be much more successful if you're out there and have to show up because your friend's there knocking on your door, and also lots more fun. So I'd encourage people, join walking groups. I don't know if there's a walking group here at your track and things like that, but generally those kinds of things are readily accessible through our leisure centers, and hopefully get active with things like that, or even Tai Chi. Get outside, and again, talk to your provider about an exercise prescription if you're looking for some more direction and need a bit more motivation on how to get started and how to continuously challenge yourself to get more out of being physically active. Smoking. So we all know smoking is not healthy for us. It is definitely a risk factor for developing diabetes. 30 to 40% higher risk for developing diabetes in smokers versus non-smokers. And the more you smoke, it's a correlation. So the more you smoke, the higher the risk becomes. And has to do with the toxins from the cigarettes causing inflammation in your blood vessels, which makes it more difficult for your insulin to work properly. Smoking increases your risk for obesity, which also, as we get heavier, we don't respond to that insulin as well. The smoking also can impair your wound healing and increases your risk for cancers, heart disease, and all the complications from diabetes. I believe that both communities have smoking cessation programs as well, which are well supported. So if you, I know in Huntsville at least, there is a nicotine replacement program that you can access for free. So for people who are needing a patch or gum or inhalers, we do have that available through our family health teams, which comes along with counseling if you wish it, to try to help motivate people to get on the bandwagon and kind of stick with their plan to quit. Diabetic medications. So I didn't want to make these slides too busy. Some of you or many of you may already be on these or know of these. The first one that we usually start with is metformin. It's our first line medication. It's cost effective. It doesn't cause weight gain. It doesn't cause low sugars. So we often start with that. Main side effects are usually stomach stuff. So nausea, diarrhea, in which case sometimes you need to back off on the dose. I've had a few people who can't tolerate it at all, but I would say the majority tolerate it, and we try to get that dose to the maximum before we start adding other things. Most of these medications kind of work in multiple ways, but metformin in general improves the sensitivity that your body has to insulin and decreases how much glucose is absorbed. Sulfonylureas, we don't. I mean, some of you may be on this medication, or you may know of people on glycoside or diamicron. We tend to use this a little bit less than we used to before some of the newer medications came out. But it increases the production of insulin and also increases the sensitivity your body cells have to insulin. So you get better glucose uptake into your tissues. Its downside is that it can cause hypoglycemia. Not as much as insulin, but it can, if you combine it with insulin or you forget to eat and you take a high dose of glycoside, you can sometimes get low sugars. So in older populations, it's sometimes a medication that we might want to try to get rid of and replace with some of the safer medications that we have now. DTP4 inhibitors, so that's Januvia. It's also called, there's another medication called Tradjenta. Those are probably the two most common. Increases the amount of insulin that your pancreas will produce, and it increases a hormone called incretin, which stimulates the release of glucose from the pancreas. We often combine this with metformin, and the name is Janumet. So it's two medications in one. It's a little bit easier to take. Again, common sort of generic side effects, usually stomach related. It does not work as well as some of the newer medications, but we often will use it because we can combine it with metformin, so your pill load isn't higher, but you're getting a second medication at the same time. So the newer things that you've heard about, so the SGLT2 inhibitors, so Invokana and Jardiance are probably the two most common. It increases how much glucose you pee out. So some people's, the main side effects actually going to be you're going to get bladder infections or urinary frequency is a side effect. Genital yeast infections or candida can occur as well, but does work more effectively than Januvia does. So this medication, probably more common in the last 5 to 8 years, we're using that. And it has the added benefits of several things. So its indication, actually, we also use it for reducing the risk for end-stage kidney disease. So because we know diabetics often are at risk for kidney disease, this is sometimes a better one to use. Or if they're diabetic and they already have kidney issues, this is a good medication to start to prevent further damage. It also reduces the risk of cardiovascular death and non-fatal strokes and heart attacks, and reduces the number of hospitalizations from heart failure. So we often will choose this medication, or you'll see specialists choose this for people who have diabetes and heart failure, or diabetes and kidney disease, or all of the above. It does help with weight loss of about 2 to 3% of your body weight, and it can reduce your A1C by up to 1%, which is higher than some of the other medications discussed earlier. Big one, Ozempic. So this is a class of medications called GLP-1 receptor agonists. It increases insulin release is one of its mechanisms, and the other is it slows the transit of food in your gut. So the main side effect is nausea, vomiting, stomach upset. It's very popular, as you know. I'm sure you're all well aware that we ran out of it, and for a long period of time couldn't get it because people were using it for weight loss. It does work very well. And the reason why it helps with weight loss, or one of the main reasons, is because it slows the transit of food. So people get full faster, they eat less, and they can drop a pretty good percentage of their weight. It is a once-a-week injection. Usually that's not a deterrent. It doesn't hurt more than actually poking your finger for an AccuCheck. So some people have a hesitation to having to inject a medication. Lots of patients who are like, I don't want to take insulin. This is similar type of injection to insulin and not as painful as the AccuCheck. It also has several other benefits in terms of heart-related health and reducing cardiovascular death. It reduces your A1C by up to 2%, so it can be very effective for your A1C. And right now, it's actually only covered by ODB drug plan if you're over 65, if you've already tried metformin. So lots of people will come in and say, I want to be on Ozempic for weight loss and diabetes. I can't get it covered unless you've actually been on metformin and tolerated it to the maximum dose, or you failed the metformin and you can't take it. Recently in May, there's been approval for Wegovy, if you've heard of that. It's actually the same drug as Ozempic. It's just they've changed the name because it's indicated now specifically for weight loss. So that is now available. The dosing is essentially the same. It's still a once a week injection, and the dose goes slightly higher than it does for diabetes. Insulin. We used to go from, those first couple of medications straight to insulin. Now we've got the Ozempic and the Januvia in between, so we can kind of stave off the use of insulin. But insulin is the most effective thing to control your sugars because you're replacing what your body doesn't have. And so increasing the glucose uptake in your cells. Because it's insulin and it increases your sugar, obviously the side effect is you can get hypoglycemic or low sugar, and it can cause weight gain. But it works very well. It comes in various different forms. Sometimes we use it once a day, and sometimes we use it once a day plus with meals, depending on how much glucose control you need. Some people only need it once a day. Some people actually have a spike in sugars only after they eat. And so sometimes that's better served by doing 3 times a day insulin. So what can you do to help? So get screened. If you aren't diabetic, see your provider so that you can get yourself checked every 3 years or so, depending on your risk factors, so that you know if you're having asymptomatic diabetes, and then can make sure that you're dealing with that if that is the case. We talked about healthy eating and exercise and to quit smoking. If you have diabetes, then you should see your family doctor. Usually it's every 3 to 4 months. Every year we'll check your feet. Every year we'll check and make sure you've seen the optometrist to check your eyes, and we'll monitor that A1C every 3 to 4 months. If you don't have a provider, I was just going to stick this in there, if you don't actually have a family doctor or a nurse practitioner to be able to do this kind of care, obviously the Emerge is not the place that you want to be going for that. There is a clinic in Huntsville. It's called the Huntsville Healthcare Clinic, also called the Annex. So if you know people that need that care, anyone in Muskoka can access that. And we do primary care there. So we do diabetic management, we do screening, we do all of the things that you should have access to, or everyone should have access to. There are a couple of diabetes prevention programs through both family health teams, Cottage Country here and Algonquin Family Health Team in Huntsville. Both of them are geared towards a more in-depth weekly discussion about how to get active and how to eat better. So they have talks from the dietitian. The Huntsville one has an actual walking program as well to try to get people started. Its focus used to be on weight management. It's now more focused on just healthy lifestyle. And that's all we have. So, questions, yeah. You can be, yeah. So oftentimes the hierarchy is metformin and a bunch of other pills, and then Ozempic, because people tend to not want to go to Ozempic first. But we definitely have patients who are on metformin, Ozempic, and then adding insulin in if they're not well enough controlled. So sometimes the weight is tempered a bit by the Ozempic. Oftentimes we'll maximize the Ozempic to its highest dose to help with weight management so that we can also minimize the amount of insulin that you'll need. So technically on the formulary, it goes up to 1.7 milligrams per week. The Wegovy goes up to, I think it's 2.4. So I've had patients up to 2. You could do 2.4. It's all a bit of a marketing thing and what you're able to dose based on who your funder is. But you can generally go up to about 2 milligrams for diabetes. Oh, sorry. Yeah. I don't know. So the question was, what was the highest dose of Ozempic for diabetes? And typically it's about 2 to 2.4 milligrams per week. Yeah.
You mentioned about an exercise program, more preferably after a meal. I find that my exercise regimen is much more effective prior to, and I've tried it after, even like before a couple of days. I experience a lot of distress because I'm generating a lot of gas, painful. So if I do go for a walk, usually about 40, 45 minutes, I find it preferable if I have nothing to eat and nothing to drink.
Before your exercise?
Yes.
Okay. So if you're diabetic, you just need to be careful that you're not going to drop your sugar, right? So if you're requiring, if you're on glycoside, you're on insulin, and you go and exercise and you haven't eaten, you do have the risk of becoming hypoglycemic. So you need to be a bit aware of that, because in the short term, a low sugar is much more dangerous than having a high sugar. So we really want to avoid anything that causes hypoglycemia. But I think what you're asking is it better before or after? I mean, you actually get benefit for hours after you exercise. So I think, is it helpful to exercise after you eat? Yes, but really it's whenever you can fit it in a most consistent manner. So if it works better for you to do it before, do it before, if that's more reliable for you. Like I said, I would just be careful that you don't run into problems with low sugar because you haven't eaten and then you're exercising, both of which are going to drop your sugars. Yeah. Any other questions? Sure. Yeah.
Just repeat the question.
Okay. So the question was, what is the cause of urinary tract infections? Yeah? Okay. So yeah, there are a number of different causes. I mean, sometimes it's just bad luck. So in the physiologic sense, it's when bacteria from your skin or from your GI tract get up into your urinary tract where they shouldn't be. That's one of the main causes. It is a myth that wiping the wrong way or that kind of thing is going to increase your risk. Hygiene doesn't have anything to do with it. So sometimes we don't know when people keep getting repeated urinary tract infections what the cause is, but no, there's no clear evidence that I'm aware of that, washing and wiping in a certain way increases or decreases your risk. What is a risk factor for older women in particular and men is if you don't empty your bladder because you have a big prostate or because you have organ prolapse and urine is kind of stays like just sitting in your bladder, that's a risk factor for growing bacteria. The other risk factor that you can have is kidney stone. So if you've got something that's stuck in there as a focus of infection, some people will get repeated bladder infections. And so oftentimes if I see that, I'll do an ultrasound just to make sure there's nothing anatomical happening or no stone. Yeah, if you're sitting in stool, that is going to increase your risk. So in a slightly different fashion, that makes more sense if someone is incontinent as opposed to someone like who is able to wipe and do their own personal care effectively. Those kind of things tend to be not a risk for, not senior citizens who are struggling with incontinence. Yeah. Yeah.
Metformin and Ozempic. I've tried others and I've increased my physical activity to 3 to 4 hours a week.
Great. Okay.
Actually, center here. And I can't understand why my tests are coming up higher now. Can't understand.
Like consistently over months?
For the last 2 months, I've increased activity in the last 3 months. My blood tests are coming back higher than they've ever.
Okay.
The finger medic is coming back higher.
Yeah.
So I don't know if it's my machine or if it's the exercise.
Okay. So the question is, why are her sugars getting worse now that she's exercising more? So I don't have an exact answer for you, but I mean, what I would ask patients if their sugar's going up when we don't think it should be. So first of all, you want to make sure you don't have an infection. So if you have an infection, if you're on prednisone or steroids or some kind of medication like that, or a class of medications called atypical antipsychotics, which we use for refractory depression, we use it in dementia, things like that. So certain medications will jump your sugar as well. So you kind of have to look at, is there anything new? Do you have a bladder infection? Is there some other thing that's affecting your sugar? Obviously, if you've changed your diet, that can have a factor as well. Sometimes it is the monitor. I won't lie. There's certainly patients who go get a monitor and you check it in the office and you check it on yours and it's different. So, you can consider that. I mean, I would certainly check those things first. But I don't have a physiologic reason per se as to why. I mean, the other thing you have to consider too is that the natural history of diabetes is you do become more resistant over time and you start producing less. So the natural history is that your sugar or your glucose control is going to get more difficult the longer you have diabetes. Not that that's exactly what your cause is, but I would speak to your provider just about that. Yeah. Any other questions? Okay, well, thank you all for coming. Next time I'll make my questions harder because you guys knew a lot. So thanks so much for coming.